Dr. Michael Gossweiler is an integrative periodontist who has practiced both in the United States and Germany. He received his DDS degree from the Indiana University, I have to say that correctly, School of Dentistry, and has postgraduate certification in periodontics from the University of Kentucky College of Dentistry. In 1994, he established a specialty practice in Indianapolis, Indiana, and in 2005 began incorporating holistic practices such as nutritional counseling and blood chemistry analysis. He has taught as an adjunct professor at the Department of Periodontology at the Indiana University School of Dentistry. Since 1995, he is a member of the American Dental Association, Indiana Dental Association, American Academy of Periodontology, and the International Academy of Oral Medicine and Toxicology, where he is chair of the Periodontology Committee. He has published journal articles in the Journal of Periodontology and other professional journals as well. He is also a board member of the International Scientific Committee on Ozone Therapy and has recently completed work on the dental section of the third edition of the Madrid Declaration on Ozone Therapy. He has conducted medical ozone research at Indiana University School of Dentistry along with his wife, Dr. Anna Gossweiler. Where's Anna? There's Anna right over there. Hi, Anna. All right, he has lectured at conferences on the topic of periodontics, implant dentistry, and dental ozone therapy since 2012, and he currently lectures on the topics of redox biology, sorry I said that wrong, as it relates to periodontology, implantology, and regenerative dentistry. Please give a warm welcome to Dr. Michael Gossweiler.
Thanks. Appreciate it. Sure, no problem. All right. So I have to read the disclaimer. I do not have any financial interest of a product in my talk or with any companies offering grant monies for this continuing education and medical education program. I will talk about some products, basically diagnostic devices, but again, I don't have any financial relationship with them other than I buy some of their materials. But I did want to bring some of this stuff to your attention because I feel that it's part of what we need to be doing in order to really provide better care for our patients. So, is there anybody out there who feels like, okay, that was really interesting lecture by Morley, but it's kind of like drinking from a fire hose, right? I mean, it's a lot of material to take in if you're hearing it for the first time. For me, yeah, I'm like back in the back cheering and going, this is wonderful. But I'm going to just throw it open a little bit. For those of you who are, I guess, a little bit more outgoing, what are some of the aspects to this that you think are really going to be difficult in your practice? Let's say, okay, I accept what Morley's saying here, but gosh, how am I going to implement this in my office? Anybody? Think the vitamin D thing might be a problem? Anybody? Yes? Yeah. Or the vitamin C, right? So how are we going to deal with that? Well, yeah, that's an issue I think that you're just going to have to take one step at a time. Let me just relate to you a little bit about what my journey has been with this, because it's not necessarily been easy, but it has been rewarding. There's a lot in dentistry where we are really kind of accepting other people's expertise. And while Morley is certainly an expert in mineral physiology, I still look at this and think, okay, let's see how we can apply this practically and test it clinically to see what kind of results can we get. So for a long time, I think I've probably been in this mode where we all think our reality is what's actually happening. And of course it's not. It's a matter of perception. And as Morley's talked about, this perception can be altered by our belief systems. Just keeping in mind that LIE in belief is what kind of pulls us away from reality, all right, or actuality. That is, our reality gets altered by our belief system. So what we really need to do is increase our ability to perceive these things accurately. This is where testing and trying to use other diagnostic means really is beneficial to see if what Morley's talking about is actually getting us where we need to be. Because as we do this, then our reality can move closer to actuality. So some years ago, back in 2019, I had become convinced by a well-known dentist in Europe that my cavitations were causing my low energy problems and my knee problems. So I decided to have cavitation surgery by an excellent oral surgeon who removed all 4 of my cavitations in the 3rd molar sites with ozone and PRF treatment. This was me after about 5 days after the surgery. I had purulent infection drainage from both the 17 and 32 sites. And in the weeks and months after the surgery, I had dysesthesia and even lower energy than I had before. I had 2 more surgeries with PRF that simply did not resolve the problem. And at one point, my wife, bless her heart, was doing intraosseous ozone injections on me on a weekly basis just so I could function. It was not a lot of fun. But what I came to eventually realize that the problem wasn't just one of trying to get rid of an infection, but the problem was that I had an iron dysregulation problem. I didn't really realize it at the time and didn't really understand any of this. But it really wasn't until I started getting more into Morley stuff that I started actually resolving some of these problems. So on a very personal basis, yeah, I can attest to how this has really helped me personally, because I'll tell you, most of the time when you go and you talk to experts on this, they'll tell you, well, you know, you can try this. I mean, I was throwing ozone at it, everything that I knew. But basically, what most of them were telling me was this: sorry, we can't help you. So there's a quote by Marcus Aurelius that misfortune nobly born is good fortune. I didn't really think that at the time when this was going on. But it turns out that it did force me to start looking at pain coping strategies for my patients. So I've become very good at trying to figure out what people need to do if they have these types of dysesthesia problems. The other thing it caused me to do was re-examine my assumptions about pathology and regeneration and start to abandon this. You know, this is the center of germ theory, is basically all about the pathogens. And very frankly, we need to get rid of this. Then it also forced me to come up with an alternative strategy. Now, in the 1880s, there had been debate about the competing theories of disease etiology. So, you know, probably most of you are familiar with this, but basically Pasteur and Koch were these 2 well-known, well, one was a physician, of course. Pasteur was just I shouldn't say just, but he was a pharmacist. But he was not above trying to plagiarize other people's work. And of course, what he was promoting and what Koch was promoting was a very convenient narrative for the pharmaceutical industry. It was just coming into being at that time. Of course, there was Antoine Béchamp, who had this more complex theory. And of course, as Morley's already pointed out, people prefer a simple lie over a complex truth. In fact, towards the end of his life, Virchow, who was still considered the father of modern pathology, had a quote, and he said, "If I could live my life over again, I would devote it to the idea that pathogens seek out diseased tissue, not the other way around." And that basically his analogy was that mosquitoes do not cause the swamp, right? They seek out the swamp. Forward. So this is the problem, though, with the terrain theory, is that we don't have a physiological model that explained why we have low energy and how we develop bacterial or viral infections. course, this is what got me into thinking about this because I come from a microbiology background. And I knew that low oxygen and unbound iron were part of the problem. But of course, once I started running across what Morley was putting out there, I started realizing that the periodontitis problem is an oxidative stress problem. I mean, I knew that already, but I just didn't know how the iron was being dysregulated. Again, there's plenty of literature to back this up. And what he was explaining was basically that oxidative stress is not this lack of antioxidants, it's the whole thing about poor oxygen utilization. So now, when I get up to lecture about this, I'm trying not to blow people away, trying to make this as simple as possible about this whole idea that basically the problem with our use of oxygen is we're producing bad exhaust. You know, the mitochondria are essentially like little engines that are helping to produce energy. But if they're doing it in a fashion that isn't utilizing oxygen correctly, that is taking the oxygen and converting it into water, then what it converts it into are reactive oxygen species. So we need to understand that oxygen really has this kind of Janus effect. You know, it's good, but it's also can be dangerous. I'm going to run through that real quick. So here's a brief video to just kind of demonstrate this.
Today, students, we're going to learn about oxygen. Element number 8, atomic mass 16, and an ambitious young student in elementary school. It's time for recess. Let's observe as oxygen tries to make friends on the playground. Here's helium all alone on the carousel. Not having much luck, is he? Perhaps oxygen can give him a hand. See that, students? Oxygen repels helium, much like a magnet. Looks as though helium has gone off to play somewhere else. Seems here that oxygen has made friends with iron. It's unfortunate, however, that they won't be able to play on that seesaw for long, since oxygen causes most metals to rust. I think someone should get the nurse. Oxygen has recovered quickly from his little bump and can now be seen playing with barium. But they should be careful playing in that rocket, since oxygen is often used as ignition in engines. Curiously enough, barium is also used in fireworks, which produce a brilliant green hue. Don't be sad, oxygen. Maybe hydrogen can be your friend. See? Nothing bad will happen. That is, unless a second one jumps in. That's it for oxygen. Be sure to watch our next lesson where we investigate the effects of helium in the upper atmosphere.
All right. So this whole idea that we generally have about oxygen being this kind of benign thing that we just need more of it, something we need to kind of readjust our thinking on. But I think it also points out why perhaps when I start to think about ozone, I mean, you see how reactive oxygen is. Ozone is even more reactive, right? So we need to think about when we're using, for instance, like ozone in our patients, this is a even more reactive molecule that frankly the patients need to be able to respond to appropriately. So if we don't understand what their oxidative capacity is to begin with, then we really shouldn't be throwing ozone at the patients. I mean, I was recently in Brazil back in October, and I actually was speaking with a couple of other physicians, well known, I won't mention their names, but they were using direct IV ozone gas, which I talked to them about, and they said, we've never had any problems. It's always been fine. I said, well, do you ever get like adverse reactions? And they're like, well, yeah, occasionally. But it's a Herxheimer's reaction. Like, well, what does that mean? Well, of course, detox. And said, yeah, but what's the physiology of that? Can you explain that to me? Well, not really. I got some answers that really, frankly, didn't make any sense. But then I proposed to them, I said, well, what if the problem is that you've basically overshot the patient's oxidative capacity? They were like, never really thought about that. But maybe that's why the patients are having an adverse reaction. You understand, right, that when you do ozone, it's an oxidant, and you're depending on the patient's ability to essentially be like a trampoline, right? You're throwing this steel ball at them, and you're hoping that it bounces back. Well, if they don't have that, if their springs are broken and the pad is torn, it's not going to happen. So that's really what Morley's talking about, is making the patients a better trampoline. Basically, that their oxidative capacity is increased by doing what he's proposing. So, anyway, oxygen, reactive element, we need it for energy, but of course, we also need it to be converted properly. And if we don't do that, then oxygen is basically radicalized. And part of the problem here is this iron dysregulation problem. Right? If iron is readily available, during this process where oxygen gets converted into water, it basically has electrons added to it. So you have these hydroxyl radicals, oxygen anions that are formed. And if you have free iron, unbound iron, that's anywhere in the vicinity, that's going to be causing a Fenton reaction. Basically, you're going to start to produce exhaust. So this is why it's important to us, that we need to have a good model of what causes inflammation, and we also need to be able to get predictable outcomes. This is why perio is so frustrating for most people, is because we don't really understand the basic physiology. The AAP is still stuck in this bacterial-centered mode. I presented this material at Indiana University to our graduate department, and I was expecting all kinds of resistance from this. I was ready to do battle. I had all this literature ready to, and basically I did this 3-hour presentation, and I said, okay, questions. And they're like, nope, sounds good. I'm like, well, come on, like you're not going to even argue with me about it? And they're like, no. What this is pointing out to me is what the AAP has out there. Are you guys familiar with the term Potemkin Village? You know what that means, right? It was like, Catherine II? She had a boyfriend who was this general who was always trying to impress her, and she goes to review the Crimea, and since he didn't really have all of the troops and everything that he was supposed to have, they constructed this fake village and fake facades, just so that when she was passing by, they called this the Potemkin Village. That's what the AP has. They've constructed this fake facade, and that they're just hoping that nobody pushes on it too hard. But when you really start to question this whole thing about periodontal disease, and how is it that bacteria are causing this problem? Why are we saying that that's the primary etiology? Again, the literature doesn't really back it up. And there's very few people who are willing to basically, researchers who are willing to say that only because they don't want to endanger their NIH funding. So we have more of what we call an energy-centered periodontal program. And it's not that I want to go through every single step of this. But you can see that we do rather comprehensive exam, photos, models. We want to have plenty of information. But you can see that the second step in this is this point of care testing, because we want to know what is the patient's oxidative capacity. If we're going to start doing anything invasive, and a lot of my practice is really patients coming in saying, you know, I have these failing either periodontally involved teeth or endodontically involved teeth that I want to get rid of. Or maybe I've got failing metal implants that I want to have replaced. Well, before I start stressing these patients with doing any kind of regenerative work, any kind of implant, I really want to know what their oxidative capacity is. How well are they going to bounce back when I start stressing them? Now you see also the third point here is the traditional blood chemistries or full Monty. The point of care testing that we do will only give us a small window into what's going on. It's not the same as what Morley talks about, this full Monty. The full Monty will tell you, so one of the tests that we do is to assess whether iron is dysregulated. Well, okay, if we find that iron is dysregulated, it doesn't tell us why. It just tells us that it's dysregulated. Is it because there's a lack of bioavailable copper? Is there a lack of retinol? Is there a lack of magnesium? Is it all three? We don't know. That's where the full Monty comes in and kind of gives you a more complete picture. I'm going to stop here for a second. I know we've got people in this audience that do implants, and certainly ceramic implants. And I know some of you have failures. You have to. I mean, if you're telling me that you don't have failures, you're a liar, okay? Very frankly. So tell me, like, Reed, are you doing implants or you refer them out? You do. Right. So you're one of the few people that know about this stuff, but are doing implants, right? So tell me a little bit about what are you doing as far as, like, you know, let me ask you this. What is your biggest challenge with patients in terms of, like, implementing the RCP and doing implants? Hang on a second. Can we use the mic so they can hear what he's saying? Yeah. Go ahead. Sorry.
Yeah, so it's not just around implants, and you're right, implants fail.
Right.
And I'm happy I'm not placing them. One of my colleagues are, because he has to deal with it. I don't. But I'm trying to educate him and the other and the patients that if you need an implant because something failed in your mouth, so we need to clean up the terrain, and this is the way to do it. The biggest challenge we've had with Morley's program is the time it takes to educate the patient, because it's a totally new paradigm.
Right.
You know, and personally, I'm much happier shotgunning it. Say, let's just get you on a few basic minerals, change your diet, because we know diet is important, and I hope for the best. But my frustration is when I see patients either with moderate to advanced perio, and we want to keep those teeth. We don't want to extract them.
Right.
We want to just doing our traditional non-surgical perio. I know in some cases it's not enough. And we need to really move these patients from point A to point B and change their thinking.
Right. Right.
Yeah.
So this is where then some of this point of care testing comes in.
Right.
So again, I'm not trying to advertise, but these are the few tests that I found that, again, in the office, you can use to, like, quickly try to kind of guide the conversation. Because, you know, patients, I'm sure you get this too when you're trying to implement this, is that you say, are you doing the RCP? And they go, oh, yeah. Well, like, so what are you doing exactly? Now, when you start to get down to the detail, then you start to really find out if they're actually following through. Yeah, go ahead. There you go. I agree with you. That's a much better way to state that. You're right. Yeah, because it is a bone failure. Thank you. But yes, it is a bone failure problem. Yeah, because the implants, again, they're just responding to whatever the terrain conditions are that we're, trying to force that into. Exactly. But that's why we're calling this energy centered, right? So what I'm going to run through is basically kind of a narrative that we run through with patients in order to try to get them moving in the right direction. Basically, we present them with this idea of what is disease. Sorry, let me do this. Of course, we think of disease being a separate entity, or most people do. That it's either due to faulty genetics or these overly aggressive pathogens. But what if the problem is really one of a faulty paradigm? What if there really is no such thing as disease? Because if we have inappropriate diagnostics, we're going to get inappropriate treatment. So then I'm usually going into this thing about talking to them about terrain theory versus germ theory. Again, we've tried to put this together as a little booklet for patients. We know that, for instance, the bacteria will respond to whatever the conditions are. And this has been validated repeatedly, but the narrative always is the bacteria are driving the problem. And this is what Perio has been trying to do for 70 years, is basically push this narrative. The problem is that they can't really demonstrably prove with literature or any type of research that that's what actually is going on. So with the terrain theory, we're looking more at the energy. Biofilms are opportunistic organisms, and that's the main point you want to get across to patients, is that what happens is that the patients are energetically compromised. We have this energy exchange system. So Morley's talking about energy basically at the base level. We're talking about at the subcellular, molecular level of energy production. But that energy has to be adequate, not only just to sustain the mitochondria in the cell, but that energy then has to be also available so that the cells can communicate. Like he was talking about with the enterocytes. The enterocytes have to be able to communicate with one another so that they maintain those gap and tight junctions between the cells, otherwise it starts to open up. Well, guess where else that happens? In the mouth. Just at the other end, right? You start to have these gap junctions start to open up, bacteria can move in between the epithelial cells, they get down into the connective tissue. We tend to think, okay, we're going to use all these rinses and mouthwashes to get rid of these biofilms. Folks, that's not where the problem is occurring. It's down deeper. So it doesn't make any difference, frankly. I mean, I'm not against hygiene. Let me be clear on that, okay? We still need hygiene. But using that as our only tool is not adequate. Also then, you have to have enough energy not just to communicate among the cells, but then also communicate within tissues within an organ, okay? And of course, each tooth is an organ in of itself. And then you need to communicate amongst the various organs. Kidneys need to know what's going on in the serum, in other parts of the body. It's not like these organs don't communicate with one another, they have to. So we try to make clear to them mitochondria are these organelles, they're producing energy. Basically, your problem is if you're not producing energy properly, you're going to be fatigued. And a lot of perio patients are fatigued. Explain to them oxygen and iron are necessary for life. You need oxygen basically to burn your nutrients. And that iron is needed to move oxygen around and also to move electrons within the mitochondria. We need to understand that oxygen is a toxin and iron is a heavy metal, and that the two together form rust. What I explain to patients is, okay, iron and oxygen outside the body is rust. Inside the body, it's worse. Inside the body, it produces what's called a Fenton reaction that can produce these reactive oxygen species, causes all this damage, inflammation, and of course, fatigue. One of the primary functions of the body in general is to keep oxygen and iron from interacting with each other. If you can get that point across to patients, you've already won half the battle. And if we can then take oxygen and then convert it into water appropriately without producing any inflammatory or reactive oxygen species, then we're good. If we don't, we get these reactive oxygen species, we have oxidative stress. And again, this is just repeating what Morley was saying, but we're accumulating iron 1 milligram a day. And as we do so, we start to exhibit the signs of aging. And as iron accumulates in various cells, we start to get organ failure. What is the tooth? It's an organ, right? Very susceptible because, again, pulpal cells are very sensitive to oxidative stress. What happens when you have a meth patient, right? Terrible decay. Why? Increased oxidative stress. Their oxidative stress is off the charts. Cancer patients undergoing chemotherapy, incredible oxidative stress, incredible decay, right? Again, using things like blood donation to get rid of excess iron. Now, I always caution patients, don't run out and just start donating blood right away. We need to get the iron under control first. Then let's think about doing that. Again, we're just repeating this stuff on the reticuloendothelial system, this whole iron circulatory system. I'm glad Morley took the time to figure this out because I certainly would not have. We have this functional iron. So we have a certain amount of iron that is in circulation, and any particular day you have about 25 milligrams of iron that is going to be recycled for the purpose of making red blood cells. You're making 2 million red blood cells like that, every second. Every second, 2 million red blood cells. So iron, again, when it's moving between these various systems, it has to change its valence state. It has to change its charge. When it does so, there's copper. Again, as he pointed out, it's the general helping to move iron from one compartment to the next. And of course, the big enzyme that's involved in that is ceruloplasmin. Ceruloplasmin is helping to distribute that to the various areas where it's needed, but it also has enzymatic functions in of itself. I used to do another lecture on this where I think Ben Edwards refers to ceruloplasmin as like the Swiss Army knife, right, of enzymes. I think I called it like, what was it? The little toys that would convert from cars into robots. What were those? Transformers, right? It's a large protein, over 1,000 amino acids, right? 1,066 amino acids. Any type of protein that's that large requires a lot of what's called post-transcriptional folding. Think of it like a origami, origami swan. Like you want to pull on it and it moves the tail and the head, right? That's only going to happen if it's properly folded. And ceruloplasmin can only carry out its function if there's proper post-transcriptional folding occurring in the liver. And if that liver is under stress because there's not enough retinol in the diet, vitamin A, it's not going to happen. You can produce ceruloplasmin, but it's not functional. And this is what you see in some of the periodontal studies. I've seen these studies where they're talking about, oh my goodness, ceruloplasmin is increased in patients with periodontal disease. Well, yes, that's true, because it's what's called an acute phase reactant. Problem is that it probably, not probably, it's non-functional. It's the body's producing excess ceruloplasmin because the ceruloplasmin that it has isn't carrying out its normal function. Again, if you have properly folded ceruloplasmin, again, depending upon whose literature you read, 6 to 8 copper ions can be transported. Another factoid about copper, that there is so much copper in the mitochondria. And this is just a few of the areas where you're going to find copper in the mitochondria. But if you took a mitochondria and you sliced it open, it would actually look blue on the inside because of all the copper. So this is the other point, though. When patients come in and they're talking, well, you know, I have to have iron. I have to have it because I'm deficient in iron. Again, this is completely mythology. Chinese researchers understand this. When you look at the Chinese and they talk about anemia, they're always talking about anemia of inflammation. Here, we're always talking about iron deficiency anemia. And it's, in essence, it's due to lack of bioavailable copper. It can also be due to a lack of magnesium, or a lack of retinol, or all three. That's where this reticular endothelial system is going to start to slow down, because the body senses you're not doing it correctly. So we're going to start to slow everything down, and of course then they get these signs of fatigue, they get these problems with lower red blood cell counts, lower hemoglobin. And of course, when it appears that there's an iron deficiency problem, what do the physicians want to do? More iron. And of course, anemia of inflammation, if you start to look at the literature, is associated with all kinds of other systemic diseases. It's associated with cancer, associated with heart disease, kidney disease, and of course, autoimmune diseases. And what is periodontal disease? It's an autoimmune disease, right? Bone loss in periodontitis is not caused by the bacteria. It's caused by the host response. If you go to the AAP literature, the AAP only has one position, or they don't even call it a position paper, they call it an informational paper on periodontal etiology. One paper, and it was written 25 years ago. When you look at that paper, they state in the paper, we don't really know what causes periodontitis. I mean, this is still their official position. Now, that is contrary to what they're teaching in the dental school. Like everybody that's gone through dental school here, you know, what is the primary etiology of periodontitis? Everybody should say bacterial plaque, right? But yet, AAP says, well, we don't really know. They're still debating it. But yet that's taught as a fact in every dental school across the country. You know, and I call them out on it. They're like, well, yeah, but you know, what are we going to do? Okay. All right? So again, anemia of inflammation is also associated with moderate to advanced periodontitis. There's 2 big review studies that back this up. Also, not as much literature on this, but certainly in kids, active dental decay is associated with anemia of inflammation in children. Basically, you know, what we call pathogens, in fact, I don't even really like the term pathogens anymore, it's anaerobic bacteria, but they essentially thrive in these oxygen deficient and unbound iron conditions. Okay, so this is what morally, and this is what we're implementing with the patient, but there's, again, certain difficulties in trying to implement this. And I'm not saying this is easy. I mean, if it were easy, then, you know, everybody would do it, right? But what I do like is the fact that Morley has put this stuff out there for free. I tell patients, go to the website, go to the handbook. Under resources, you go to handbook, and it's basically an instruction manual. Now, I have what I call my IKEA patients, right? They like following directions, and they're good at doing that. And there's others that like, no, I want somebody to construct it in my house, right? So those are the patients that are probably going to need like a health coach. Those are the ones, like you said, difficult. They need help, but they're like, I don't know what to do, and okay, fine. So this is where, again, we're talking to Morley, and there's a lot of health coaches on his website, but there's others who I think are probably more comfortable and who do this on a more regular basis. There's some people that are kind of what I call dabblers in this. Again, nutrient-dense foods. I think Sally Fallon's going to be in here tomorrow talking about nutrient-dense foods. I thought it was interesting, and I don't know, I'm sure probably a lot of you follow Mercola's newsletter. Yesterday's newsletter, anybody see that? We had the whole thing about, he was talking about Sally Fallon, talking about vitamin D. You didn't see that? See? It was really interesting. He basically said, okay, this is Sally Fallon's position on D, not mine. I mean, he went explicitly out of his way to say that. But what I found interesting was he put it all in there. Basically, same as your position on D. Like, we can't be pushing on this because it's going to dysregulate magnesium, it's going to dysregulate retinol. So I'm thinking, well, okay, this is getting more interesting now. All right? So again, this whole thing with D, that's probably the biggest impediment that, frankly, I had when I first, that's why I go to that Amish gathering, because I was like, this guy has to explain this to me. Like, that can't be right. But the other thing that kind of made me think, well, maybe he's got a point, was one of my old mentors from way back, Sam Queen, used to talk about this as well. And he would say, yeah, the literature says you shouldn't really be supplementing with D. And I thought, oh, Sam, but he was right. So we need to let go of some of these preconceived ideas, especially about vitamin D. And I try to, as much as I can, say hormone D, because it's a hormone, folks. And it's going to be low when inflammation is high. So there's a reason that D will become low. What we need to understand is, of course, D is made from what? I'm going to be brave, step out there. Cholesterol, well, Reed, you would know, right? Made from cholesterol, it gets converted to D, and everybody thinks, okay, well, that's the sunshine vitamin, right? You just need sunshine to do it. It's a little bit more complex than that. You actually need 8 magnesium enzymes and 2 copper enzymes. And if you're deficient in either one of those, it's not going to happen. The body has the innate ability to get that properly regulated and to keep the storage D, by the way, storage D what we're measuring, not active. And if you are measuring active D, you need to make sure that the blood is properly handled, because the half-life on active D is maybe only about 5 to 6 hours, right? We already talked about how supplementation, pushing it too much is going to dysregulate. Also, we need to be careful about excess supplementation, or actually just supplementation with calcium. That can dysregulate iron. Magnesium, of course, is what helps regulate iron. We talk about copper regulating iron. Magnesium regulates calcium. And of course, zinc is an important trace mineral, but again, if we're pushing it too much, we're going to start to push down the copper. Lots of things are going to dysregulate iron. Processed sugar, alcohol sugars. This is one of those things that in dentistry we love to talk about. Oh, well, it's got xylitol that the bacteria can't use. Folks, alcohol sugars are not good for trying to keep your copper levels where they need to be. Does anybody here use like monk fruit sweetener, by the way? Right. You know that you look on the package for the monk fruit sweetener, what's like the first ingredient on there? Erythritol, right. Not great for your copper. All right. Processed foods with added iron. You're feeding your kids cereals. Just take a look at how much iron is in there. Anybody seen those videos on YouTube where they're talking about how much iron? They actually add iron filings to cereal. I mean, you can actually demonstrate this. In fact, there was one video, I think they had like a bran flake floating on the water, and they took a neodymium magnet and they could pull it across the water. There's that much iron in it. Of course, processed seed oils, we already talked about. And of course, heavy metals. You have these ferrous sulfur compounds in the mitochondria that are responsible in complex 1 and complex 3, right? Well, those can be pulled apart by mercury. Of course, there's all these different things you can do to improve your energy exchange, meditation. You know, what impressed me when I first started taking Morley's course was when he would talk about, because I was expecting him to like wow the patients with all this physiology about copper and iron, but 80% of the time he's talking about stress. How do we get your stress under control? That impressed me. Like, you know, I mean, he talks a lot to these groups, you know, people like us about all the physiology of this, but when he talks to a client about their particular problems, he's usually talking about their stress. When did you have this stressful event where all these other problems started to occur? We way underestimate the impact that stress can have on this whole iron dysregulation and basically mineral dysregulation problem. Certainly, and I think probably like emotional freedom technique is probably one of your more favorite therapies, right? Yeah. Acupuncture can be very useful. Voltage biomodulation, again, some of Jerry Tennett's stuff I think is helpful or useful in some of these situations. Laser biomodulation can also be helpful. Rounding, of course, getting rid of dead teeth. But again, if you're going to start taking teeth out, you need to make sure that they've got adequate energy to be able to regenerate when you do so. Of course, you want to try to help improve sleep quality, nasal breathing. Again, this is where airway stuff starts to come into play. You know, if they are physiologically kind of set up where they can't really breathe properly at night, they're going to have more oxidative stress problems. So you see how all these things that we've been talking about start to come together in this picture of trying to regulate energy and regulate iron. So basically, what we're trying to get across is this dental disease are manifestations of this inability to produce adequate amounts of energy, essentially to keep out the microbial world. And that we need to produce enough energy that can be exchanged between the various tissues, organs, and systems in the body. Here's what you can do, all right? Again, you know, this is a group that understands these concepts. I can't necessarily talk to the dental school about some of these other issues because they just don't get it, at least not yet. We're putting together a site called dentalenergetics.net. Mind you, there's nothing on there yet, so don't run to it. I have some other stuff on here, but let me skip forward here. Just wanted to show some x-rays on a case here real quick. Questions on any of this? Later, okay, we'll wait. Let me just run through a quick case here and then. Yeah, the diagnostics here, that's how I'm going to skip forward to that. Okay, so this is one of the point-of-care diagnostics that we're doing. This is it's called the FRAS-5, Free Radical and Radical Assessment System. Again, this is not taking the place of what Morley's putting out there as far as the full Monty, but it is a lower cost means of trying to get patients to understand that they're maybe not as healthy as they think they are. I have plenty of patients who come in and they think, well, I'm doing okay. But yet, when you run this test, you start to uncover what's really going on as far as their iron. This basically is a test measuring both ferrous, the Fe2, which is the more damaging form, at least in the serum, and the Fe3, ferric. And by those two forms of iron should exist within certain ranges. And if they are out of those ranges, if you plot this on an XY axis, I put that on here. Skip forward here. You plot this out on an XY axis here. Your x-axis basically is your ferrous, and then your ferric is across here. And you can see that those two ranges then form like a bullseye. And I basically tell patients you want to be in the green zone. Now, when you do this, you're going to have some patients that are like way out to the side, and it's like, don't panic, it's okay. We've got something we can do to try to help to correct this. But I also tell patients that just because you're in the green zone doesn't mean you're absolutely healthy. All it means is that you're not so sick that I won't work on you. Okay? And because I just recently had a patient who actually he was in the green zone. We were getting ready to do the implants, and he calls me up and says, Doc, you know, I got diagnosed with melanoma. I had, a couple biopsies, looked it over, and he said, I need to deal with this problem here before I go and do the implant. So it just helps me kind of readjust my thinking and understanding that just because iron in the serum looks okay doesn't mean that it's okay in the tissues, right? And that's the point Morley was trying to make earlier, is that just because ferritin is maybe low, sometimes you see patients with a low ferritin and think, oh, everything's fine. Well, that could be a sign that iron simply isn't moving. Let's see. So again, that's something we're going to talk a little bit more about in the afternoon seminar. Dr. Niatu, who sells these machines, is going to be actually running some tests on some volunteers that we have. So if you're interested, you can attend that. So again, this doesn't tell us how iron is being handled in the bones, macrophages, the enterocytes, or the liver. It just tells us that at least in the serum, it's not being handled properly. The other test that we're using as a point-of-care diagnostics is this machine from a company. It's called Dentignostics, but it's a active matrix metalloproteinase 8 test. So let me see. I can explain this a little bit better here with some of the other slides. Basically, periodontitis is this problem where the bacteria are able to get into the deeper connective tissue, like I mentioned before. And when they get into the deeper connective tissue, you have these matrix metalloproteinases that are there in an inactive form. They're just basically sitting around waiting to be activated. And when the neutrophils, which are kind of your sentinel, like I say, innate immune system cells that are like looking for bacteria, when they see this, they start to release what are called myeloperoxidases. Now these myeloperoxidases basically will then start to produce an activation of the matrix metallo, or the hydrochloric acid and the other components of the myeloperoxidase will then start to activate the matrix metalloproteinases. And as it does so, then it starts to break down the connective tissue. I mean, normally what this is designed to do is try to clear out the bacteria. The problem is if the epithelial cells aren't able to keep the bacteria out, that problem or that thing just keeps going and going and going. It doesn't shut down. And again, eventually, then the whole immune system starts to readjust itself. You know, you have this Th1, Th2 typical, you know, yin and yang of the immune system. Well, when that starts to become chronic, what the body does is it starts to activate this Th17 part of the immune system. Well, that is basically designed to try to seal up the epithelial cells. And when that doesn't happen, you start to get autoimmune problems. So, you know, there's this thing where you read the literature and they talk about the Th17 being like the autoimmune component of the immune system. That's ridiculous. Like, why would you have a system designed to produce disease? You know, that's crazy. What it's trying to do, it's trying to basically seal the patients back up. And when it's unable to do that, because again, those epithelial cells don't possess enough energy to keep out the bacteria, then basically you do start to develop autoimmune problems. And again, that's what periodontal disease is, autoimmune problem. Again, this matrix metalloproteinase, once you start to measure this and you can see that it's actually present in the system, again, that shouldn't be there at all, right? There's two ways to measure this with this system. You can measure it as a rinse and spit test, which is great for your maintenance patients. And again, you may think, okay, well, you know, we know if the patient has periodontal disease because they've got bleeding, because they've got pockets. Not always, gang. You got some of these patients who have excellent oral hygiene, who have no pockets, no bleeding. I mean, other than the periodontist that's here, I think, or TJ, I know there's a few periodontists here. But how many of you are aware that there's this entity called non-inflammatory periodontal destruction? Anybody? Yes? Okay. How do you diagnose that? Right. Right, right. You're just sort of like watching the tide go out, right? But like, how do you know if it's active or not? I don't know. Yeah, exactly, right? You're like, but this can then measure that. So you may think, okay, well, it looks good, but they could still be losing attachment. This just tells you, at least on that day, it's either active or inactive. What I also like about this test, they also have these little tabs. This is like a little resin thing that you can stick into the sulcus of the tooth, and then you can measure whether or not that tooth has active collagen breakdown happening. All right? Now, this is useful then in teeth that have perhaps been endodontically treated and are perhaps failing. And you know, sometimes we measure endodontically involved teeth and they're fine. Sometimes they're not. I had a patient not too long ago. She came in with 3 endodontically treated teeth, 2, 3, and number 30. She had pain on the right side, couldn't localize it. I've got pain over here, I get these headaches. I think it's one of my endo teeth. Well, maybe. We looked at the radiographs, looked at the CBCT, couldn't really tell. I could tell that there was an area back in the number 1 area, it looked like a cavitation. I said, well, maybe it's the cavitation, I don't know. So we've run this test on all 3 teeth. Number 30 was 27, number 3 was 23, number 2 was 72. Which one do you think we took out? Right? We took the tooth out. She had difficulties with healing afterwards, in part because of that big cavitation she had behind there. So basically what was happening is that the tooth was leaking back into that cavitation. So we treated her with ozone, cleaned the area up, eventually her headaches resolved and she was fine. She kept the other 2 endo teeth, she was happy, she could chew, But again, that's where something like this is useful. We also need to understand that patients can have attachment loss for lots of other reasons. The periodontists in this room understand that. But I'm just pointing it out that, like, you know, just because you see some attachment loss on a patient doesn't mean it's necessarily perio. All right. And this just has to do with the reassessment. But basically what I'm trying to get across is we need to do more point of care testing. We need to start doing more assessment, looking at this from the standpoint of oxidative stress. Well, we're going to have questions. Okay. Basically, then I'm going to just end there. Thank you.